The objectives of today's presentation are, first, we're going to share some recent epidemiological data on acute COVID-19 and MIS-C in children with a focus on young children under the age of 5. We're going to look at some risk factors that are associated with more severe disease. And finally, we're going to discuss COVID-19 vaccination efficacy, safety, and effectiveness in the field in children. So really, the Omicron wave has brought on a lot of infections in children, and seroprevalence studies looking for antibodies against the nucleocapsid antigen of SARS-CoV-2 can give us a hint of what proportion of children got infected during the Omicron wave. And what you see from this figure here is that in the United States, the seroprevalence rates went from 45 to 75% among children. So roughly 30% of children appear to have been infected between December and February 2022 in the United States. And we also know from Canada and in studies from Quebec and British Columbia that have estimated that roughly between 30 and 70% of children under the age of 5 have now shown evidence of a prior infection. So really a lot of those infections have come on during the Omicron wave. And all these infections have led to a greater number of hospitalizations. Fortunately, in pediatrics, we're relatively spared in terms of the burden of severe disease. And these data from the Public Health Agency of Canada clearly show that still the elderly and older adults are the most likely to get hospitalized due to a COVID-19 infection. But what's notable here is that you see the little blue line that appears more prominently in December, February, and April of 2022. Those are children under 5. And children under 5 were the most likely to get hospitalized among the pediatric age group. And really, there are more children that have been hospitalized during the Omicron wave than there had been during the entire prior pandemic due to a COVID-19 infection. So even though severe outcomes such as hospitalization remain less frequent, the brute force of all these infections in young children led to a substantial increase in hospitalization in that age group. Now, if you look at what is the risk of either requiring an emergency department visit, hospitalization, an ICU admission, or mechanical ventilation, so really most severe outcomes after either an Omicron infection versus a Delta variant infection, you can see that it seems that these Omicron infections have a lower risk of more severe outcomes. But again, from a public health perspective, the fact that there have been so many children who've been infected, that has raised the incidence of hospitalization in young children, and it's especially high in those under 5. And you can see from this infographic from the CDC pointing out that hospitalization rates in children ages 4 and younger were 5 times as high during the peak of Omicron compared to what they were with Delta. Now, it can be helpful to try and compare COVID-19 disease severity to other viruses that we know better, such as influenza. And these are data from the United States regarding mortality related to influenza, those are the lines in red, and mortality related to COVID-19 in children, and those are the lines in blue. And you'd see that year in, year out, somewhere up to 100 or so deaths occur in the United States due to influenza. But for COVID-19, during the first few waves of the pandemic, relatively few deaths occurred, less than 50 per month. But as we went on into the Delta and then Omicron waves, the United States experienced higher mortality numbers with COVID-19 than they typically do with influenza, and that includes even the H1N1 season of 2009. So I think what this shows is that although severe outcomes in COVID-19, including mortality, are infrequent, they are comparable to what we see with other respiratory viruses. So, but what are risk factors that we've identified for developing a more severe COVID-19 infection, in particularly amongst hospitalized children? These are data from the CDC showing that with regards to age in pediatrics, it seems that perhaps children who are hospitalized, if they're less than 6 months of age, are less likely to have a more severe hospitalization course that requires hemodynamic or respiratory support. But as you go above that age, the risk of severe outcomes appears to be pretty stable across different age groups. Another point I'd like to make from this particular figure is that any one underlying chronic medical condition puts a child at risk at more severe disease if they are hospitalized for their COVID-19 infection. Now, looking specifically at different comorbidities individually, there seems to be an effect of age or age modification in terms of how they play out as risk factors for disease severity. In younger children under 2 years of age, which you see on the figure on top, we see that chronic lung disease, neurologic disorders, cardiovascular disease, and prematurity, as well as airway abnormalities, were all significantly associated with having more severe COVID-19 hospitalization. But in older children and adolescents, what we found is that feeding tube dependence, diabetes, and obesity were the factors that were most strongly associated with a severe course. Now, what about MIS-C? That's a very severe hyperinflammatory response that occurs 2 to 6 weeks of what can be after what can be a banal SARS-CoV-2 infection. Well, what we're seeing is that even though there was a very substantial increase in the number of infections, that is the dotted line, that occurred during the Omicron wave, the amount of MIS-C that was observed actually seems to have been trending downwards. So it appears from these US data that the risk of MIS-C after Omicron infection seems to be less than compared to the previous variants and the original Wuhan strain. And that was borne out also in a study from Israel that showed that not only were there fewer MIS-C cases during the Omicron wave compared to Delta and Alpha, 33 compared to 79 or 59. Each of these hospitalizations seems to be associated with a less severe course, with a shorter hospital length of stay and ICU admission rates that are lower as well. Now, what do we know about pediatric COVID-19 immunization, especially what are the data from the field on the effectiveness and safety of COVID-19 vaccination in adolescents and children? Well, let's take a look at COVID-19 vaccine uptake in Canada to date in pediatrics. We see that adolescents aged 12 to 17 have very high rate of completion of their primary series, approximately 84%, whereas in children 5 to 11, only 42% completed the primary series, whereas 56% have received at least one dose. Now, what is the effectiveness of this? These are data of the Pfizer vaccine against hospitalization for COVID-19 according to the child's age and the variant in question. So these are all actually, looking at first at the adolescent group, we see that during the Delta period, we had very high protection against hospitalization. Over 90% was offered by the mRNA vaccine. That dropped down to roughly 40% during the Omicron period. Now, for children aged 5 to 11, because the vaccine rollout only occurred just before Omicron, there only are data on Omicron protection against hospitalization. And you can see that it seems that Pfizer in the United States, the Pfizer vaccine offered protection of roughly 70% against hospitalization due to an Omicron infection in children 5 to 11. We're starting to get some data from Canada on vaccine effectiveness in the field. And this study comes from Ontario, recently published in the journal Pediatrics. And it compared vaccine effectiveness of the Pfizer vaccine against Delta and Omicron in adolescents in the province of Ontario. And what you can see is that Delta being the square box here, the black box, very high rates of protection, vaccine effectiveness against symptomatic infection, and with a little bit of waning seen after in terms of days after the second dose, again against the Delta virus in symptomatic infection, and against Omicron. There is roughly 50% protection initially for the first 2 months after vaccination, and then it drops down to about 30%. But there is an increase in protection against Omicron infection that's observed after a third dose is given or that first booster dose is given. But I think the figure on the right is even more telling in terms of the protection against Omicron severe outcomes offered by 2 doses of that primary series. And we see vaccine effectiveness that protecting against hospitalization or death at 80% or above, closing in on 90%. So we see that primary series really, although it loses effectiveness against Omicron infection, it does have quite a bit of effectiveness against severe outcomes in adolescents in Ontario. What about MIS-C? This is a study from this US CDC showing that using different methods to try and assess vaccine effectiveness amongst adolescents at preventing MIS-C, they all come out to roughly the same estimate, 90% effective at preventing that severe outcome of MIS-C. One of the main concerns in terms of safety with regards to COVID-19 vaccinations, the mRNA vaccines, has been myocarditis that thankfully has proven to be short-lived, and that almost all persons who have developed myocarditis after vaccination are able to come back to their usual levels of activity and don't have any signs of cardiac dysfunction afterwards. But it still has been a concern in young adults and in older teenagers. And these are data from the CDC showing that, yes, in particular, after the second dose in males, in older teenagers and younger teenagers, there's a significant increase in the risk of myocarditis, 70 or 45 per 1 million doses administered, whereas in female adolescents, it's between 3 and 7 per million doses administered after the second dose. Now, in children aged 5 to 11, with millions of doses administered in the United States, what was observed was a rate of 2.2 events of myocarditis per million doses administered. And depending on how you analyze the data, that may or may not be significantly above the baseline rate with regards to that second dose, and for males only. There is no increase in risk of myocarditis after the first dose in males, nor after either the first or second dose in females. So let's talk a little bit about the data that has allowed for the Moderna Spikevax vaccine to be authorized for use by Health Canada in children 6 months of age to 5 years of age. It was a randomized placebo-controlled trial, randomized 3-to-1 amongst over 6,000 children. It was performed during the Omicron wave. And what was found in terms of efficacy against symptomatic SARS-CoV-2 infection was an efficacy of 37.8% overall, varied a little bit by age groups, as you can see there, between 50 and 36%. So now that seems much lower than what we've gotten used to with regards to mRNA randomized controlled trials. But really, again, important to note that that was during the Omicron wave. And this number of roughly 40% is in keeping with what we've seen in adolescents and adults at preventing infection, symptomatic infection with Omicron. Now, immunogenicity, the study showed that the humoral response was non-inferior relative to young adults, with geometric mean ratios that were equivalent to that of adults, and neutralizing seroresponse rates which were essentially 100%. Safety, overall, there were no serious safety signals identified, and the safety was consistent with what was typically seen in that age group with other vaccines, and with the known safety and reactogenicity profile of the Moderna vaccine. And the majority of local and systemic side effects occurred within the first day or two after any dose and persisted for about 2 days. So in conclusion, what we've seen with Omicron is that the epidemiology of acute COVID-19 and MIS-C have shifted, and so has vaccine effectiveness. But nonetheless, COVID-19 vaccines have been proven to be safe and effective in children 5 years of age and above in the field, with millions of doses administered. Clinical trial data for the Moderna Spikevax 25 microgram vaccine product show that it is immunogenic and efficacious, and it has an acceptable reactogenicity and safety profile in children ages 6 months to 5 years of age.